have known better. This is Dr. Jazma Dobbins. She is the owner of Gadsden Pelvic Rehab and Physical Therapy, also located in Oxford, if you are in the Oxford-Anniston area. She is the Alabama State Representative for the Academy of Pelvic Health, a board-certified women's health clinical specialist, and LSVT big therapist. She has a passion for working with the Parkinson's community, and for those of you that have been to Jazma, you know it's just a joy to walk in her office. I'm biased because I've been there a lot, but her staff is fantastic, and we're thankful to have her. So welcome, Dr. Dobbins.
Thank you. Let me get set up here a little because my fancy stuff wouldn't work with your stuff. Fancy stuff, Canva. You can have a seat. We're going to move some in a minute because mobility really does lead to motility, and we'll talk about that. I'm going to grab my emotional support pelvis.
Feel free to take that off.
Take this off? Okay, I can do that.
Then you can move.
Oh, look, I'm all about moving. I just make sure that you can see what I'm doing. So I want to talk to you today about some of those non-motor symptoms that Dr. Abrall mentioned before. Bowel and bladder issues are some of the most prevalent non-motor symptoms in Parkinson, and they're also some of the most underreported non-motor symptoms. And some of it's embarrassment, nobody wants to talk about it. Some of it's they didn't realize it was linked to their Parkinson's. But there are things that we can do to help. So just some objectives. We're going to describe normal function, we're going to describe Parkinson's related function, and we're going to discuss some conservative options to manage it. Okay, this is a really complex slide, but I'm going to break it down pretty easy for you. On the left side of the screen, so micturition, that's a fancy word for peeing. On the left side of the screen, the neural control of micturition just means how your brain helps you pee. And we actually have different motor and sympathetic and parasympathetic nerves that go from the bladder to the spinal cord. In Parkinson's, that signal is disrupted. So normal voiding, this is your pelvic floor, and this is your bladder. Your pelvic floor is a little contracted. You don't have to do it, it just does its thing. And your bladder's relaxed, and it's filling up with pee. And when it's time to go sit on the toilet, we sit down, and our pelvic floor relaxes, and our bladder contracts, and we go. But if our signal is messed up, sometimes we get a mismatch. So instead of our bladder contracting and our pelvic floor relaxing, we get both contracting and then both relaxing. And you can see where that's problematic in trying to hold your pee. It's an issue, but it can be helped. So normally how the bladder works, our pelvic floor muscles are a little contracted and our bladder's relaxed, and it works off of stretch receptors. So as your bladder's filling up, we get about halfway full, and it sends a signal to the brain, hey, I might need to pee. And we get a little more full, and it says, hey, let's make a plan. And we get much more full, and that is like, I'm fixing to go without you. And fortunately, we have that mechanism to protect our kidneys, right? So our kidneys don't like our bladder to get backed up. It increases the pressure, and it can cause kidney damage. So we get those signals to go, and we get that urgency to go so we don't hurt our kidneys. But when that signal's disrupted, sometimes what happens is our bladder continues to fill, and we don't get the signal that we need to go. Or more frequently with Parkinson's is we get too much signal. So with Parkinson, these are Parkinson-specific statistics. Say that 3 times fast. Parkinson-specific statistics. The most common, the most prevalent is storage problems. So being able to hold your pee. And these are across all genders, right? So men and women. The most common symptoms are urinary urgency and frequency and nocturia, or having to get up to pee multiple times at night. Now, over the age of 65, getting up one time is normal. How many people are getting up more than once? Right? I see a lot of hands. It's true, though, right? But we can help with that, and we're going to talk about that in a minute. Another problem is an emptying problem. Now, although these are Parkinson's specific statistics, they are not they didn't take into consideration other age-related changes, and some of this is coming from the prostate, the good old prostate. It's the only organ in the human body that continues to produce cells throughout your lifetime. It's not a matter of if you have BPH, it's when, if you have prostate. So some of this weak stream and hesitancy and incomplete emptying could be coming from your prostate. See your urologist, they can help you with that. Now, the most common bladder issue with Parkinson's that's actually pathological or is the neurogenic bladder. So it's a lower urinary tract disorder. That means it affects your urethra and your bladder. Your upper urinary tract is your kidneys and your ureters. It's prevalent in 37 to 72% of the Parkinson's population, depending on what study you read. So it's a pretty wide range of people. But what happens is your bladder contracts uncontrollably, right? It's uninhibited because that signal from the spinal cord to inhibit or calm down the bladder doesn't make it there. And when that happens, our bladder does this. And when our bladder does this, we feel like we have to go a lot. And it's really, really hard to calm that signal down on its own. And so it can lead to urinary urgency, frequency, and urge incontinence, and something that's the most common cause of falls in Parkinson's, functional incontinence, trying to get to the bathroom in time. You can imagine if you really got to go and you're having a hard time moving, how hard it is to get to the bathroom in time. But these are things that we can help. So how do you know if you have a neurogenic bladder? Well, you need to first tell your healthcare provider, right, so they can send you for something called a urodynamic test. It's a little invasive, but it gives you a lot of information. So they do a catheter into the bladder. They'll do a sensor into the vagina or the rectum, depending on your anatomy. And then they do sensors on each side of the external pelvic floor muscles. And they're going to learn how fast is your stream. Is your bladder emptying all the way? Is there still some left after you've gone, right? Or you have incomplete emptying? And they do this test to make sure that your kidneys are going to be okay, because that's really important. We can manage this stuff conservatively, and with medications, doesn't necessarily need surgery, but we got to make sure that your kidneys are doing okay. So how are we going to do that? We can do something called percutaneous tibial nerve stimulation. It's a mouthful, but I'm going to break it down for you. So right here, this is an area called the sacral micturition center. It's a fancy word for your P center in your spinal cord. It's in your sacral spine, so your low, very low back. So this area right here. And our tibial nerve in our leg shares an ascending up the tract pathway with that sacral micturition center. It's so cool. And we can tap into that nerve in our leg and affect changes in our bladder. We can affect this signal in our bladder doing that. The tibial nerve stimulation, it's done with acupuncture needles. So they're tiny. They're like the width of 2 hairs on your head. They're tiny little needles that go into a muscle called your posterior tibialis. And we do a little electrical stimulation with it. It doesn't feel like electricity, it feels like tapping. And that is actually sending a signal up the chain and helping your bladder stop spasming. It works really, really well. Now, there's some Parkinson's specific data on percutaneous tibial nerve stimulation. So Cabet et al. Is fancy for, and other people, in 2009 did this really great study. They had 19 men, 13 women. The ages were 44 to 78. These people had Parkinson's. The average length of time that they had Parkinson's was 6 years in this particular study. So for 30 minutes, 1 day a week, they did the tibial nerve stimulation, and they did this for 12 weeks. Now, they repeated this study 2 years ago, or actually 4 years ago now, over the course of 2 years, and they found that the effects remained, right? So they redid the study. And what they found was after the program, after the 12 weeks, they had an improvement in 104 milliliters of urine before your bladder started to spasm uncontrollably or unintentionally. The bladder itself could hold 90 more milliliters than it could before the program on average. So this is a pretty big amount, especially considering the size of the bladder. So some other improvements. So the number of times per day that the person had to go to the bathroom decreased by 5.6 times per day. Normal time to pee in a day is 5 to 7. And some of you have gone 5 to 7 since we've been here. I've been counting. So just know, that could be a problem. Urinary urgency, so the number of times that you felt like you needed to go, decreased by 3.1 times per day. And your urgency decreased by over 6 times a day, and then the urgent continence, actually leaking because you had to pee, decreased by 3.1 times per day. And my favorite statistic, these folks got up an average of nearly 2 times less per night. It is hard to sleep and get good sleep and rest when you have to get up every 45 minutes. It's just hard. Now, a cool thing, I've got too far ahead of myself, a cool thing about the percutaneous tibial nerve stimulation, it doesn't have to be needles. You can do this. Now, you gotta make sure that you've had your bladder checked, like see your doctor, make sure your kidney's okay, but you can do this with a home TENS unit. You can take your TENS unit, and if you haven't signed up for our door prize, there's one in there. You can take your TENS unit, and you can set it to 12 hertz, 12 HZ, 12 hertz, and you're going to put it right here. Okay, I need to work on my balance. You're going to put it on your lower leg. I can show you later. JP can show you. He's really good at it. You're going to put it on your lower leg, and you're going to do it for 30 minutes, and you're going to turn it up until it's strong but comfortable. You can do it before you go to bed at night, and that can decrease the number of times that you have to go pee, and the number of times that you wake up because you've got urgency. So if you do one thing today, that's something simple that you can do. You can get a unit on Amazon, and it really does help. Now, it doesn't help as much as the tibial nerve stimulation. You got to think about the needles are electrodes, and the end of the needle is the electrode, whereas a TENS unit, you're using stickers over the skin. But man, what a simple way to help manage some of your urinary urgency and frequency. Now, some other things. A lot of times when you have to pee a lot, you reduce your water. You're like, I don't want to have to pee all the time, so I'm not going to drink as much. But we're made of water. We've got to have water. Our colon needs us to have water, our bladder needs us to have water, and our brain needs us to have water. We can avoid bladder irritants. So caffeine, citrus, alcohol, and carbonated beverages are all bladder irritants. It doesn't mean you have to give them up. I'm not giving up my coffee. But what you got to do is drink a bottle of water before, and then enjoy your coffee, and then drink a bottle of water after. You got to dilute it in the system. Caffeine's a bladder irritant, and she's already spasming on her own, or his own. So another thing that you can do is urge suppression. Children do this automatically on their own. Nobody had to teach them, but they hold themselves, right? They feel like they got to pee, and they hold themselves, and you're like, stop, we're in Walmart. But it's helping, right? They're managing, they're urge suppressing, and it really does work. So if you're not at Walmart, if you're at home, and you feel the urge, put pressure there. It works really good. Then you're going to distract yourself for a few minutes, right? And when that urge is gone, and you're not feeling this super anxious, then get up and go pee, right? Because some of that is where our brain is and our bladder's trying to take over our brain, and we've got to retrain it out of that. All right, PTs are all about movement, including bowel movements, and mobility leads to motility. So let's do our 5 times sit to stand. Everybody ready? All right, ready? We're going to do it. Let's sit down. Let's do it. 5 times in a row. Here we go. Ready? Everybody's getting nice. We're safe. All right, here's 1. 4. types of bowel movement issues. It's a can't keep it in problem, a can't get it out problem, and it hurts. Anybody have an idea what we have with Parkinson's most commonly? Can't get it out, right? Can't get it out problem, and that leads to it hurts. So, of course, there's a chart. PTs love charts, and there's a poop chart. It's called the Bristow stool chart. Now, these first two right here, I don't know, can y'all see my cursor on the screen? Yeah? So, these first two are a symptom of not having enough water in your diet. So the water that we drink is absorbed into our body in our colon, and the longer stool sits in our colon, the more water is absorbed from it, the harder it gets. The harder it gets, the harder it is to pass. So drink your water, it's really important. These bottom two, that's normal, and then we get into the diarrhea stage. I'm hurrying, Cindy, I know it's your turn. So another thing that can happen is we can have tight pelvic floor muscles. So just Parkinson's, tends to cause the muscle rigidity. It happens in your pelvic floor too. So we have a muscle right here. It's called our puborectalis, and she comes up and loops around our rectum, and it creates something called the anorectal angle. And when that angle is really short, because that muscle's tight or rigid, it's like pooping around a corner. It's just hard to go. Right? But we can help that muscle stretch. We have these muscles out here to the side that help to hold up the bladder and the rectum and the uterus if you have one. And they're going to help support and help us maintain continence. So our pelvic floor muscles play a huge role in all of this. Another thing that you can do today to help your bowel movements is going to be getting a squatty potty. Who all knows about the squatty potty? Yes, it's a game changer. So if you'll take my emotional support pelvis, if you can see from the back, if we sit on a normal toilet seat, our pelvis is in this position right here. So we're pooping uphill. But if we elevate our feet 6 inches or so, that's going to change our angle to here. And it's going to have gravity help us go. And it's going to open up that tight anorectal angle. So we're no longer pooping around a corner. Now, it doesn't have to be a squatty potty. They are nice. They're particularly nice for this population because it goes flush against the commode, so it's not a trip hazard. But one of my girlfriends uses her husband's toolbox. It doesn't matter. Right, get your feet up. Get those feet up. So some other things that you can do today to start helping your bowels move. Drinking plenty of fluids. We should be drinking half our body weight in ounces. 60% of that should be water. Eating something that you have to chew stimulates the gastrocolic reflex. Using a stool or squatty potty, drinking something warm can help stimulate those reflexes and get moving. Get moving. All right, my take home today. Dr. Abrall mentioned this, and I want to head it back up. Speak up. Tell your doctor that you're having these symptoms. It feels embarrassing in the moment. They've heard way worse, I promise. Let them know if you're having trouble holding your bladder or if you're having trouble with constipation, because they can't help what they don't know that you need help on. Now, I didn't make up anything that I told you about today. It all came from research, so I can't take credit, although I wish I could. So if anybody wants to see a list of references, I'm happy to share that with you. And thank you.